Thank you for coming back. Saturday morning, sun is out, weather is beautiful. Well, here we are inside, continuing this journey. So the focus this morning is really looking at what we learned yesterday in terms of the clinical imperative, the technical aspect, and also on a greater scale about technical ecosystem that we should try to facilitate to make this technology work for us. So this morning, this session is about looking at the clinical and industrial ecosystem to how we could take advantage of these emerging technology and how we apply them to make sure that they work in the clinical setting. So we have 4 speakers this morning, and without further ado, I'd like to invite Dr. Heinrich von Busch. He comes from Siemens Healthcare, and he would like to share with us the vision of what a company typically would think about adopting this sort of technology into their products. Thank you very much, Heinrich.
Yeah, good morning, and thank you very much for the kind introduction, and first of all, for the kind invitation to be here and to be part of this exciting event. While I listened to the talks yesterday, I noticed that one by one, many of the points that I wanted to make were already ticked off. And so I reworked my slides a little bit in order to make it more interesting. And the focus that I'm trying to take is more on the craft aspect of AI than on the wizardry. And I think that's only fitting because in industry we are, our role is, has more of an emphasis on the last mile of taking the innovations to a polished product that can be readily used. So these are my conflicts of interest. I'm an employee of Siemens Healthineers. I've been formerly an employee of Royal Philips. And let me start with the aim where we're going with this. And there has been this unfortunate suggestion that AI is the end of radiology. And that is definitely not what we have in mind. So when you look 20 years back, 1997, when for the first time a chess computer was able to beat the reigning human world champion, the same questions came up. Is this the brain's last stand? And the answer was, at the time, and it still is, no. One aspect of that is the fact that playing a game is similar to playing in a sandbox. You have limited statuses that the system can take, and it's also very clear what the figure of merit is. You can create almost infinite data by playing yourself, and that is not an equivalent to the more complex tasks that you face in radiology. The second aspect is you will not be playing against the machine. You will be playing on the other side of the table, and if there is any danger in AI, then it's only for the radiologist who doesn't have those tools available. But I think that's not what we're discussing here. So these will be tools in your hands that will help make you more efficient and also support you in getting quality. From an industry perspective, one of the main aspects of AI is this enormous hype that has been formed around it. So when you look at the publication curve that you see on the right-hand side here, you see that interest in AI was actually going down in the early 2000s, which happened to be the same time that many machine learning algorithms actually made their way first into products, as in automatic scan planning, automatic positioning of slices, for instance, in MRI scans. that was the time when that happened. Still, in the academic world and in the publication numbers, the interest was going down. And it only came back when deep learning became available. Excuse me. And the reason for that is that suddenly there was the promise of actually going farther, taking bolder steps and getting higher accuracies out of these algorithms. And what was following really was kind of a gold rush, and that has led to the formation of many new companies in this space. And this is an analysis by Signify Research, and I don't believe it's even complete, but it shows the most funded new companies that were formed. So this is focusing on startups, but then on top of these companies, then there's also all the established companies in medical imaging who also invest heavily into AI. When you look at what AI can do, there are so many things. And in order to narrow down the scope a little bit, let me focus on the different steps where AI can support the imaging process. It starts with the imaging itself, basically workflow automation, scan planning, also in reconstruction, creating an image in the first place, modeling, using advanced physics. These are spaces where AI can already help. Then there is the next level, when you already have an image, and it comes to the interpretation of that image. And then you have the tasks of measuring and quantifying what's in the image, detecting, and hopefully even giving a hint of what the diagnosis may be. So that's the next level. But then there are further levels still, where you take in, next to the images, also other inputs, such as lab values, information from the electronic medical record, what have you, other information that you have about the patient. That brings you into the domain of clinical decision support. And then you, of course, can take it yet another level higher in terms of aggregation and look at population health questions. Most of what I will be showing will be working on the first two levels of this pyramid. And the question is, what are the topics that we want to focus on? And I had the good fortune to be part of an ISIS focus group in 2017, where we were able to ask the question to the leadership of ISIS, which applications do you expect AI support to come in most urgently? And you see a nice match there. So acquisition consistency, basically, which speaks to the workflow automation and also workflow standardization. There was the remark that, in particular in MRI, a lot of time is spent on the consistency. Quality assurance, automatic use of prior imaging. So this is one block. And then there's another block that speaks to automatic measurements, tedious tasks, really, that just take up your time and really don't necessarily exhaust your capabilities and your interests. High volume, low reimbursement tasks. Another question would be, can you exclude abnormalities so as to reduce the workload so that you can focus on the cases that are most interesting? And then, there was on the other hand also the suggestion of, well, how about particularly complex tasks where radiologists struggle today? And I will show examples of both buckets here. What is the goal in all of this? And well, this is how we have phrased it for our platform for AI, that we focus on speed and accuracy. And of course, they are not totally orthogonal. If you are very inaccurate, you will also lose time at some point because the quality just isn't there. But the point I want to make here is that speed seems to be the dominant one. And there was this very blunt statement, let me say, by Dr. Chang, when he said efficiency trumps quality, although, of course, we pay lip service to quality. And I think there is some grain of truth in that. If we basically can show you that something really saves you time, we have a much easier time explaining to you why you would want to have it than if we say, well, actually, it doesn't save you time, but maybe you will be a little bit more accurate. Or you will get extra information. And then the question will be, well, why do I need that extra information in the first place if I don't need it today? You have an algorithm that does some things that I don't do today. Nice, but what's in it for me? Another point is regarding the approach. So how will these solutions, and when you look at what kind of solutions we are talking of, these are point solutions. These are solutions that address one specific issue. How will these solutions really come together in a way that affects your workflow and your work in a broader sense? And that requires an ecosystem. And I think that's also a general trend that you see across the industry, that everyone is stressing, well, we have this ecosystem, we have these app stores where you will be able to choose the algorithms that you need, basically to create your own collection of tools that you would like to use. Then what are the steps, maybe from a technical end, that we're looking at? If you want to look at, from a very fundamental viewpoint, you could say you start from an image, you want to arrive at a clinical decision at some point. But there are a number of steps in between. So the analysis of the image itself can already have value. For instance, the automatic identification of image quality issues. That can have value already. Then the next thing is to identify structures in the image. So as, for instance, landmarks that you can use for automatic scan planning, or the identification of whole volumes like organs. And if you are able to segment such organs, and we had a lot of discussion about segmentations, there are a number of things that you can do with that already. Think of auto-contouring for radiation therapy, as we discussed yesterday. That is a tedious task that can be taken over mostly by a machine. Then the next level will be to quantify the structures that you've seen, and to identify which of the structures that you see may be abnormal. Abnormalities become findings when they have clinical meaning. And probably as far as you can take it from images alone is a diagnosis. Oftentimes, not even for a diagnosis, the images will be enough. There may be other sources of information that you will need to take into account. But that's maybe as far as you can go. And then certainly for getting to a clinical decision, for deciding on the next step in the clinical path, you will definitely want other sources of information as well. Why I'm showing this is because there are a number of solutions out there that really live at different levels of these steps. And it's important to realize how one builds on the next. One example that we have recently announced is a bundle of analysis for CT chest imaging. And it starts with a number of segmentations, identification of structures, and a measurement of those structures, quantifications that are created in the background and are available at the moment that you open the case. And in order to be comprehensive enough, you look at the lung. You have a block that looks at lung nodules specifically, and also at areas of low X-ray attenuation. Then you have a block of algorithms that looks at the vascular system, at the aorta. It segments the aorta, shows it visually, but also creates measurements at different spots along its path. Then you have a block that looks at the heart and quantifies the heart size, but also identifies, visualizes, and quantifies calcifications in the coronaries. And then you have another block that looks at the bony structure, such as in the vertebra, so that you have an automatic identification of the individual vertebra and measurements of their height at different positions, anterior, posterior, and in the middle, so that you can immediately highlight in color, for instance, any compression that there may be. So this is an example of a number of evaluations, mostly on the level of segmentations, that come together in order to hopefully aid your workflow in such a high volume, low reimbursement case as CT chest. A somewhat different case is this one, and I need to stress that we're not the only ones who are working on this. There are, I think, on the order of 10 companies and groups, certainly, that look at what AI can contribute to a complex task like prostate MRI evaluation. Here you have the situation, you have multiparametric MRI, different sequences that need to be evaluated and appreciated at the same time. And it is something that is not part of standard radiology training necessarily. It has a learning curve, and even experts don't necessarily agree. And the question is, well, can AI, can automatic analysis contribute something here? And the kind of thing that we are discussing here is it possible to automatically analyze the image to identify lesions that are suspicious in the image, and also to classify these lesions, so as to be able to propose and pre-populate a PIRATES report. Is that possible? And how far can that take us? And one of the reasons why this is particularly interesting is because this particular procedure is getting a lot of attention now, that in the guidelines, in the European guidelines of the European Association of Urology, actually MRI has now moved before first biopsy. So there will be a lot more MRIs of the prostate that are going to be done, and the question is, who are the people who are going to read them? And will that even be possible without the support of tools like this? I promised you to also look into the doing and the craft that is behind that. So if you want to do something like this, what are the things that you need to do? So first of all, of course, data collection. We had an extensive discussion about that yesterday, but let me stress a couple of particular points. So when you, for instance, move from a CT case to an MRI case, you have inherently much more variability through the different protocol parameters. And even though you have the PIRATES standard for prostate MRI, there's still some variability and significant level of variability in the appearance of the images that come from different tweaks of the protocols, different MRI scanners, different field strengths. Then you have the patient variability, different patient cohorts. You may have patients that come in really at a very early stage. You may have patients in countries that don't do so much PSA screening, that come in at a point when actually you have a rather advanced case, and that shouldn't fall through the crack either. And then you have the variability that some sites are still using an endocoil, others are just using external coils. And all of that contributes to a situation where you have a lot of variability out there that somehow needs to be exposed to the algorithm in the training phase already for it to become robust towards that variability. And the way that you can practically go about it is to collect data from many different sources. And that's a challenge, because each source, of course, each collaboration partner that we discuss with always thinks that their data is actually quite exceptional and should have particular value. And, well, we agree it does have value, but the appreciations of how much we actually value is actually supported by the business case behind such a solution, they differ, and those are difficult discussions. Then, even if you have well-annotated data from excellent centers, you still have a lot of variability in how the annotations, what the annotations look like. And that goes back to the discussion that we had yesterday. Well, can't we just do annotations on the fly and basically have them integrated in routine? Our experience is that is not easily possible. And there are numerous examples where we really have to go back and re-annotate the data. Even though the annotations are okay, they are not done in a harmonized way. They work for a certain institution, but if we want to pool the data together, it no longer works. I mentioned the variability of MRI, but then there's also the question of truthing in the presence of significant inter-reader variability. There is this paper by Andy Rosenkrantz, for instance, where even expert readers are shown to disagree in many cases and have a relatively low concordance in their PIRATES scoring. And then there is variability in the interpretation of the PIRATES standard. And I'm not just talking about PIRATES 3, which is known to be difficult, and because it's basically the category where you sit on the fence, but even PIRATES 2. We have, from excellent university centers in Europe, we have two different views. We've seen two different views. One side that says, of course I assign PIRATES 2s because it tells my referrer, I've seen something, I don't think it's malignant, but it might, for instance, explain an elevated PSA. So that's why I need to expose that to the referrer. Then we have another side saying, well, we don't want to make our referrers all whooshy about something that is actually not relevant. We don't assign PIRATES 2s, even though the standard asks for it. So that is something that you need to iron out when you pull together the data. And then there's the regulatory part. Looking at DCE, for instance, that is something that is required by pirates, that is reimbursed in the US, but it's not actually accepted by the FDA. It's off-label, and if you want to create a tool that analyzes that by AI, the FDA says no, so long as you don't show so long as you don't get contrast for the prostate approved. And then there is the requirement, and that goes to the validation for actually showing that the whole thing gives an improvement. And this would be if you identify lesions and if you classify lesions. This is a CAT-E, CAT-X device, and that requires a reader study where you need to show that the radiologist with the tool has better clinical performance than without the tool. Let me show you an example of another case in X-ray mammography. This is the case of the Transpera from the company ScreenPoint, where they have gone through such a study. It's quite a lot of effort. This pivotal study involved almost 7,000 reads, 14 readers, 240 cases, 2 reads, one with, one without the support, and with some washout period in between. And you see that in this case, they could show actually that there is an improvement in the area under the curve, and that basically lifted them over the barrier to clearance. Let me sum up and basically try to formulate a couple of take-home points. So AI for imaging is about new powerful tools for the radiologist, not about a replacement. That much is clear. Getting an AI algorithm polished and really ready to use is a collaborative effort, but it has the characteristics of an industrial project. In particular, the requirements for annotation are often higher than what is covered routinely. You may want, for instance, an automatic segmentation of the lesions, which is something that you may not always do in clinical practice. You may just put in a distance line and that's it. So these are annotations that actually need to be added to the data that comes from your routine work. Then, if data is the new oil, I think it's important to realize that many drops from different wells need to come together in order to have something that really works. So it's not a single site, it's not a single collection of data that does the trick. Efficiency and quality, probably in that order, are the drivers. Smooth workflows integration is essential, otherwise you can't have the efficiency. It's challenging though. Individuality in annotations and use may be significant barriers. And then, for the foreseeable future, AI solutions will be point solutions, and you will need an ecosystem and app stores really to tie it together to make it something where you can really enlist that support of the algorithms in an efficient way. Thank you for your attention.
Yeah, I'd like to walk around a bit, so. Good morning, everyone, and thank you for inviting me here. I am from the IBM labs, so just to emphasize, I'm from the research labs of IBM, which are the academic wings, so similar to most of you in academia. But we do address the issue of going from research to commercialization, so I thought we would talk about the wizardry of AI from a practitioner's perspective as a data scientist. So I thought I would talk about 3 topics today. One is, first of all, introduce you to what is actually beyond deep learning, what is happening in latest research in the community that goes beyond deep learning, and then open it up to some of the research problems that we are trying to address. Many of the things that were articulated yesterday actually have origins and active research going on in the data science community to address some of these. And then get to some of the commercialization aspects of AI and radiology, and maybe present a different perspective from my other colleagues, and going into areas a little bit different, different sections of the clinical workflow that one may also sound as easy targets for AI. So let's look at first going beyond learning and look at the era of cognitive assistance and what we mean by that. So if you look at the evolution of clinical decision support, they started, as you know, from rule-based expert systems in AI, which were mostly looking at knowledge-driven processing, where knowledge was acquired by clinicians and put into systems, and then rules were derived and then were used to infer. Now, as you know, these things didn't fly very much because either the rules were never complete or they didn't quite apply to your patient. So then came, CAD systems. So we have talked a lot about CAD systems. There again, the focus was on single sample evidence coming from your patient's data, and then using, again, built-in rules in the software in order to do the interpretation. But as electronic health records became available, people realized that there's a lot of information you can mine off of the records themselves. And so concepts like patient similarity came in, where the idea was that you don't need to do the machine do the diagnosis. There's actually pre-diagnosed patients in the population. And if you could find patients who are similar to your patient, then you could infer from what was the diagnosis given to such patients, what were their treatment, what were their outcomes. So this was a rule-free way of doing decision support that was scalable and could be personalized for your patient. Now this was, again, a contrast to the knowledge-based approaches where things came directly from data. Now the wave of deep learning came along, and now you see that the hype is almost peaking, and maybe I would say going down a little as people realize the promise and the potential, and also see the limitations. And again, the concept there was that you don't need to have custom designed features, but you could have machines infer the features and then use the machinery of neural nets to actually do the classification. But at the very heart of this, they are mostly classifiers and any application you may build around those. Again, this is a pure data-driven approach where much of the data decides. But people have now realized that the next generation of things to look at are cognitive assistants, which are actually now trying to combine both data-driven processing and knowledge-driven processing and bring the two together. So this is where we see the field is going. Going forward, you will hear terms about cognitive assistance in various settings. So let's look at the radiology setting and the radiology workflow, which all of you are familiar with in terms of the cycle that the information flow happens right from your clinician all the way to doing your radiology orders, do your workflow, go back into the EMR system, and then present. Now, if you look at this cycle, you can see where AI is now beginning to impact pretty much at every step of your workflow. Going from machines, which we just heard, you can have intelligence built into the machine, so you image it right in the first place, know that this is technically qualified to interpret. You can go to your PAC system and get a work list prioritization so that even if the machine doesn't do the diagnosis, at least it can order the cases for you so that the more important cases are seen first. And then when you come to interpret the image, you can now have the holistic clinical context about the patient and get clinical summaries, and then go and do the analysis from the front office to the back office, where you now can go and audit and do 100% peer review of things happening. Previously, only about 2% peer review happens in hospitals. So now you can see the power of AI doing 100% clear review, and then coming back all the way to the clinician so they have all this information back into their circle. So this is where we see the role of AI emerging at different points in your clinical workflow, and not necessarily for CAD that most people think AI is good for. And in fact, there's much more lower hanging fruit in these applications. So a project that I lead at IBM is called a Radiology Grand Challenge, and Grand Challenges as they go are large-scale exploratory initiatives that we try to do. You've heard of the chess game, we have heard of Watson Jeopardy. So this is something in imaging that we are trying to attempt, where we are actually trying to take this approach of bringing in data and very large-scale data sets. When you're talking about millions of patients' data, bringing that information and informatics derived from there, but then learning coming from top down as well by incorporation of knowledge. So the key factors that you see going forward in AI that will be different is not just deep learning, but the application of knowledge and reasoning, where you need to solve the problem in an end-to-end way and do it with an enterprise setting so you can actually be embedded as part of the clinical workflow. If the data acquisition itself fails you, then there is not much hope in getting the rest of the solutions going. So solving the problem right from the beginning so that you can silently collect the data from enterprise systems, go through the analysis, and bring it back would be the methodology we speak about. So what do you mean by end-to-end system analysis? It basically means you have a raw sequence, you have to start from there. And this might be in a PAC system line. First recognize that that is in fact a CT. Know from the CT at what position on the body are we looking at, and what is the right position to look if you are actually trying to interpret, say, an embolism. to know that you have got the right image. All of this can now be done through deep learning, and there are publications that talk about this. You have to extract the various anatomical structures through segmentation methodologies that you've all heard about, and then do the analysis to know that these variations are actually representing anomalies. But to interpret the anomalies, you need the clinical knowledge to drive you as such. So one of the investments that's going to be important to make in the community is to build this large-scale clinical knowledge. We've started this effort in research, but I think there is more work that needs to happen in there. So right now, the UMLS knowledge is already accumulated in knowledge graphs, but they need to be actionable for use in the systems. And what do we mean by reasoning? When you go to reasoning, you will have flowcharts or differential diagnosis flowcharts that is in your heads. Those things need to be externalized and made it computational so you can actually infer from there for a given case the conditions. So you can see over here an example for a pulmonary embolism where you have to reason with knowledge. To illustrate all of this, we actually did partnership with RSNA in about 2016. I think many of you who attended RSNA 2016 may have already attempted this case, but I just wanted to illustrate that for you with an example and how these things come together.
To experience the eyes of Watson, you can select a case for analysis.
You can examine the imaging study and read the associated case description. Select the appropriate conclusion. To see how Watson would attempt this case in real time, select Ask Watson. Watson examines the case description first, analyzes text, and highlights the relevant clinical concepts found. It summarizes the findings and updates the evolving clinical inference.
Next, it analyzes the imaging study systematically by successively looking for more and more meaningful features that could potentially be anomalous until it locates a potential lesion. For this, it uses a combination of low-level image processing to highlight suspicious regions that are then classified as potential masses using deep learning networks, trained by prior anomalous data labeled by clinical experts.
Watson then takes the clinical concepts derived from the imaging exam and case descriptions, and begins its reasoning process using clinical knowledge. Paths are explored and scored in the knowledge graph while searching for related concepts and facts that lead to the specified conclusions, starting from the chosen clinical concepts. The retained conclusion is the one which has overwhelming evidence from the number of high-scoring paths that lead up to it. The final clinical inference can be seen on the right.
You can see there is an example. So what you saw over there is that it's not enough to just give the answer, but also explain. And so explainable AI is now an active area of research where knowledge graphs navigation is one such methodology, but there are many other approaches that are coming in where
To
you
experience the
sorry. So yeah, we did this study. We have some interesting results that we'll be publishing, but at the top level, you can see that the adoption of AI is going to be a function of how formal clinical studies you do and whether you put these tools in the hands of the clinicians. And it seems yesterday when people asked how many people are willing to try, a number of people volunteered. So this shows that the data is actually backed up from the study that we did, which has about 7,000 cases and about 3,000 radiologists who participated. Okay, so now let's go to looking at some of the open problems that are there in this field that actively being worked on by medical imaging and AI researchers. So if you ask about are we there yet, there are early successes, yes, all right, but as you heard from yesterday, the accuracies are not quite there yet. And in fact, what do we mean by accuracy is actually an open question as well in this case. So here I've highlighted a few key problems that people are actively working on. And I won't have time to go through all of them, but I illustrate some of them as I go along. So at the very least, when we talk about deep learning architectures, people are looking at the first wave looked at convolutional neural nets and derivatives of that in one form or the other, whether it's for segmentation purpose or for classification purposes. But people are now beginning to question that are convolutional filters sufficient, or is there more information that you can bring to bear so that the deep learner doesn't have to do all the hard work in figuring it out? Then when we talk about incorporating domain knowledge as reasoning, I think you have seen already an example of what we mean by those and explainable AI. But now we talk about data sets and how much training data is enough. I think yesterday we had the discussion, the smaller number of data sets may still be good if they are well curated and so on. But when we are talking about very large number of findings and doing full reads, you have to have very large number of data sets. So there comes with their problems of labeling such data sets and coming up with an industrial approach for labeling such large data sets. So we'll show you how we are trying to address that in research community as such. And then the importance of doing formally powered clinical studies. People talked about reader studies, but there are also powered clinical studies where you have to take the incidence in the population into account to develop such. In fact, when I first saw the requirements for building AI products and the sensitivity and specificities for them, I said, oh my God, not many research articles will meet those needs. So you can see some of those coming up as well. Okay, so let me go quickly through examples of recent work in which these problems have been addressed. So first, the issue of what should the deep learner itself consist of and what inputs should it take. Right now, the methodology is just feed the image in and you would figure out, the machine will figure out all you need to know. It turns out that that is harder than necessary. There is a lot in computer vision, there's a lot that people have done to realize that there is information available in a data-driven manner that you can extract from imaging as well, in particular salient objects. So here's an example of, I don't know who can see on the left, a hemangioma case in the last row. It would be very difficult initially for the deep learner to figure this out without a large number of examples. But a simple bottom-up saliency operation can highlight that region, as you see in the second column, and then going forward from there, isolating the anomaly would become easier. In fact, you can show that by architecting the network, by taking combinations of input, you can not only reduce the learning time, but also do it with much simpler networks. So that the depth of the network doesn't necessarily have to be very deep and make your computational power as such also become an onus for you, but you can actually build simpler networks if you incorporate some more intelligence into the processing as such. Next, we talk about labeling. And I think this is a place where I want to focus a little bit more on because it has been talked about yesterday as well. And when you talk about labels, there are the two questions that need to be answered. First of all, how many labels are there? I think this is something that not enough people think about, but when you're doing a full read, for example, a full chest X-ray read, do we know how many findings are there in a chest X-ray? No, so coming up with a full catalog of those findings and therefore labels themselves becomes an interesting research problem. And doing that requires a lot of clinician input. So this is where you need cooperation between clinicians and machine learning researchers to even derive the labels. So we did one such effort in lexicon building for chest X-rays where we've come up with a set of labels, and you can see the comparison to what is being done in literature for chest X-rays where a handful of labels of most popular findings have been selected. But if you want to do a full-blown chest X-ray read, you need to be able to cover a much larger set of findings. There are over 2,000 findings that one may have to do. Now, when you get such large number of findings, have we built deep learning classifiers for 2,000 labels? How would we even go about it? So getting that problem solved also becomes an important issue as you go through. So now let's talk about labeling. When people talked about labeling, I heard yesterday that there are certain approaches to mitigate the problem of labeling. The way we look at it, there are at least 3 approaches one can take. One is to do clinician-sourced, or what you call as crowdsourced, but do it by clinicians. And if you can build such systems that do that, you can actually build active learning methodology into such labeling systems, so you can go ahead and reduce the need for labeling going forward. You can also now try automatic labeling approaches that have come through, whether it is looking at a whole image or regional labeling. So a little bit of verification later on, but doing a larger upfront work automatic is the current operating way to go for labeling. In fact, you can see some systems out there. There are many other examples, but here's one that we are actually offering for the community. If anyone is interested in using it either internally or in a cloud-based way, you can go ahead and do those as such. So you can do a number of features in these systems. But the idea is the active learning paradigm is that here's an example study where there were 9,000 samples to annotate, and we had the clinicians essentially annotate about 1,000 of these samples. And then the machine went ahead and developed a learner and then started predicting. And then the corrections were done. For those that were wrongly predicted, the clinicians corrected them. And within 5 to 6 iterations, we had labeled the entire 10,000 patient data set. So that is a methodology that one could think of using as this is the active learning paradigm. You can build those into the tools themselves, so you integrate learning while training as such. There are other things that I won't talk a whole lot about, but just to know that when you want to augment your data for learning, the GANs are a popular approach. We were able to do that for chest X-rays, but there are other people working on use of GANs for data augmentation, as well as the use of semi-supervised approaches where you can take a portion of labeled data and a portion of unlabeled data and actually build objective functions that you can jointly optimize by combining the two. So there is the latest work on semi-supervised learnings with GANs that you can actually utilize for your labeling problems. The last approach I talk about is auto-labeling from textual reports. Now there is a fair amount of text analytics technology out there that you can go ahead and interpret. Just because we have built clinical knowledge, you can actually interpret text and know when something is a finding, when something is an anatomy, when something is talking about a positive evidence or a negative evidence, and thereby build both positive and negative examples of findings. Here's a study we did. We had about 600,000 images to label and only 6 months to do it. We started with the crowdsourced effort. It took about 4 months to get to 36,000 images, and we said we're not going to happen. So we had to come up fast with an approach that would quickly use the remaining time we had to finish the labeling. So we came up with this approach of automatically extracting the findings from textual reports. And once the predicted findings were then, it was very easy for clinicians to manually verify those. They were able to do that through simple verification through spreadsheets instead of using advanced tooling for image-based verification. This again assumes that the radiology reports themselves are correct, but modulo that, you can reduce the, so you saw that we were able to actually in 4 minutes label about 500,000 images, but then it took about a few more days to actually go ahead and do the manual verification. So, and it's important to do the manual verification despite the advances in text analytics. And this is one of the problems, as you saw from NIH data set that was released for chest X-rays. Not doing the manual verification caused a problem. So this you can do at a whole image level, but what about when you want to get to a region and you want to annotate a region? Say you are taking cases of cardiomegaly and you want to get to the heart region. And again, this was a very time-intensive operation, and there is actually new work now where you can combine some annotations given by clinicians with reports, and then actually do a multimodal network that combines 2 different networks for text and image, either post or pre-combination, to actually make a prediction for anomalies as well. So this is some of the latest work in trying to do auto annotations for regional anomalies as well. So this is something that you will look into. Okay, so now building to accuracy specifications, we talked about what do we mean by accuracies. The most popular way people deal with accuracies is throwing ROC curves and using the area under the curve. Most practitioners of AI use that to indicate their performance. And the hard news over there is that that is not good enough for turning into a commercial application, because that sensitivity specificity curve that goes is actually taking into account, it looks good a lot of the time because of the large number of negative examples. So when you talk about performance, you not only have to look at ROC curves, but you also need to look at PR curves, or the precision recall curves, so that you can look at both sensitivity and specificity in an appropriate context and not have to account for a very large number of negative examples that make your results look artificially high. In fact, if you look at the commercial readiness criteria for detection of findings, these are some of the numbers that is expected of software. The specificity is about 99.6% for a deep learning algorithm. It may be possible to reach sensitivity that way for deep learning, but to get to specificity of that type is very difficult, particularly when you have very large number of labels. Deep learning gives a lot of false positives, and narrowing that down is actually what is disabling many commercial applications of this. So I hope I've given you a spectrum of some problems that are there that people realize and are actively trying to solve, and there will be more such work coming up. So now in the last few minutes I have left, I wanted to talk about commercialization of AI for radiology. There's a lot of work happening in entire healthcare industry for commercialization, but if you just focus only on clinical decision support, there's a number of companies, I think the previous speaker also talked about. The reality for most of these companies is either they cannot make enough money, so AI is still not financially viable for most of these companies, so either they join with big vendors or they have to fit in the clinical workflow. So having a web-based service that you can send the data to and come back is not going to be financially worthwhile for people. Having said that, there are quite a few tools that are good over there, and many of the areas that you can see cover as such. Among the use cases that I want to emphasize is that there are many low-hanging fruits in back office use cases, as well as front office, doing the simplest things first, for which AI can work reasonably well and will still be useful. So one such concept is radiologists now interpret imaging and based on imaging alone and a very little clinical information. What if you could give a surrounding clinical context? Now this part can be easily solved by AI, mostly through text analysis, but you can actually form clinical summaries and so on. So there's actually a new product now that IBM has come forward with that does gives you a patient summary that goes directly off of the pack, so that as soon as an image comes up, you get a clinical summary of the patient, and you can interpret in the context of those. So these are simple examples where 510K submissions may not even be needed, but it's something that will immediately help the radiologist. The other application is of a clinical review, which is something that I'm going to skip now given the time we have. But it's again 100% peer review analysis that we did a study for one particular disease for aortic stenosis, and you can see some results over there that nearly 30% discrepancies are found in large hospital settings where the data that is recorded by the radiologist or cardiologist is not actually making it into the EMR system. Discovering those discrepancies itself could be valuable for all aspects of clinical care, from patients, impacting the patients, to reimbursement for hospitals, as well as improving the quality of care by the clinicians as well. Okay, so I know I went through 3 different topics a little quickly, but just to give you a summary, that the future of AI is there. It is here to stay. It's not going away because there are a large number of researchers actually working on solving critical problems that, that limit its deployment. Having said that, there is regulatory concerns that will also delay the introduction of some of these, but there are many low-hanging fruits, applications in clinical workflow that AI can actually work now reliably, and I think something to consider. As far as giving back to the community, being an academic-style research lab, we are happy to contribute to open source data sets. So there is a chest X-ray data set that we are making available for a workshop that we are running for labeled data sets for tubes and lines, which I think is interesting to researchers. And then as far as annotation toolkits and so on, we also have available. If anyone is interested, you can contact me. Thank you.